Thank you very much, Erling. I'm really happy to be here with everyone around. Many thanks for joining as well. I'm really grateful for being able to be here with you and to speak about high intensity focus ultrasound. So that's great. Thank you for joining in. I have taken some kind of liberty to select aspects of high intensity focus ultrasound. Obviously, it's a very broad topic, and I'll try to cover some of the important things. I'll start with some general idea of what the high intensity focus ultrasound is, where is it used, how widely spread it is, and then I'll go and sort of rewind and talk about the basics of the acoustic wave and then focusing techniques and then basically I will finish the presentation with or the webinar with one selected application that is really close to my heart, which is high intensity focus ultrasound for dermatology. And I would, just maybe one word about the company. We founded that company called TwoSonics 5 years ago with my dear business partner Torsten. We are based in Denmark, and we are solely dedicated to developing high intensity focus ultrasound solutions just for the benefit of people. That's basically what we do. Let's carry on. The basics, the very basic of the HIFU is as follows. I mean, we start with a transducer. We'll talk about that later. We have to produce some kind of converging wave that will have certain focal points. And let's say it has one focal point. So the idea is very attractive because then it allows us to target some of the organs or pathologies deep in the human body. Obviously, we need to have a certain setup. We need to have the transducer. We need to have some kind of a coupling or coupling medium. And then we need to transfer the energy to that focal point. So that's the basic idea. It's very attractive because it's non-invasive. We don't have to open the surfaces or open the body of humans. That's fantastic. It's non-ionizing, non-vapor generating, which is actually an interesting feature that is really important in certain kind of treatments. And I usually add that it's not a laser. I mean, sometimes I have similar talk to let's say medical doctors, and it's really sometimes the message doesn't come across that we are dealing with a mechanical wave that is basically being transferred through some kind of medium into the internal parts of human body. So that's really the basic concept. It's a simple concept. Actually, the ultrasound in medicine, or in medicine, I think it started in 1940s with actually idea of using focus ultrasound as the first application of ultrasound, and I think it was they were trying to use some kind of a quartz transducers to do some kind of transcranial brain ablation. So that's really how the ultrasound started in medicine. Anyway, so moving forward, so and that so we need to understand what kind of effects we need to expect from focused ultrasound. And I'm bringing some kind of graphics after a Focused Ultrasound Foundation. That's a fantastic place, by the way. It's a fantastic organization that is sort of mapping the applications globally. And they are promoting Focused Ultrasound Foundation. And for those who are actually listening and are looking for some kind of a funding or PhD project or something like that, I think it's a fantastic place to turn to. Just for the simple fact that they are actually really interested in promoting and funding research projects, especially in medical focused ultrasound. Anyway, coming back to the topic, so we should expect, let's say, 4 different effects from focused ultrasound. 2 of those, with a different color, they're actually both non-thermal. Actually, Focused Ultrasound Foundation is sort of separating this BBB opening, which stands for blood-brain barrier opening as a separate one, but nevertheless, there are non-thermal effects, which are mostly mechanical, related to those mechanical effects of focused ultrasound, such as cavitation and streaming and things like that. Then we have hyperthermia, which is basically heating up, and could be mild hyperthermia, it could be strong. Then we have something that is really sort of being developed recently, which is histothripsy, which is turning tissue into liquid basically instantaneously, using very high intensity ultrasound. And then, at the bottom, we have thermal ablation, which I believe is actually the effect that is very much used at the moment by many different systems in the field. And again, as you can see, there is several different effects that can be applied to sort of the same different applications. Sorry, in different applications. For example, we can have those non-thermal mechanical effects that are actually supporting drug delivery. It could be also hyperthermia that is used for drug delivery, or targeting or targeted drug delivery. So that's why you have all those sort of confusing arrows. Anyway, we should understand that ultrasound has several different effects in biological tissue that can be used for our benefit in several different applications, and the number of applications is really rapidly growing. As we can see on this little graph in here, actually, this is a map that is again published by Focused Ultrasound Foundation, sort of showing the different indications and with being developed at different stages of development. That is actually sort of color coded, or from the green to the very dark, which stands for this US reimbursement, which means that it's a very mature, or it's a mature indication that can be actually treated with focused ultrasound device. And you can see this number of indications is growing. Last year it was 139, I believe. So it's around 20 new that are coming into play every year. And then let's look at those devices that are already in the market. The first ones that were actually approved for use in the US and in the European Union, there were actually those devices for uterine fibroids, prostate cancer, and those for essential tremor. We have some graphics related to those devices. Starting from the one on the left-hand side, we have this prostate cancer devices. Successfully being applied in the field. Then actually, something that I didn't mention before, the one of the aspects of focused ultrasound that was sort of keeping the focused ultrasound from being developed was the lack of imaging techniques. And actually, the HIFU as such really started the growth because of the presence of let's say MRI and more advanced techniques, just sort of allowing for precise targeting of internal human organs. So there's a number of devices that are actually MRI compatible and are guided by MRI. There's one for bone metastasis. There's another one I'll jump now on the right hand side. There's a very complex device, comprising of thousands of small little HIFU transducers forming some kind of a huge HIFU array for targeting of tumors in human brain under the guidance of MRI. So these are the devices that are in the market. The one from Theraclean that is actually designed for thyroid cancer and breast cancer. They're also there, very advanced, very effective. I think the one thing that I want to sort of emphasize on this or using this slide is that those devices are, they all use HIFU. They are using this high intensity focused ultrasound. However, they have different structures. They have different guidance. They have different form. And that's something we should always remember. You know, there's no one single transducer or one single device that will do it all. Well, then coming back to, you know, how many treatments there are, and actually in 2021, that's the most recent kind of result, is that it was actually around 100,000 total treatments using focused ultrasound. And you see, I mean, the top three are uterine fibroids and the you know, pancreatic tumor. That's actually very interesting, and liver tumors. So they actually make up 3/4 of applications. However, you know, looking at the right-hand side, we can see that it's really growing, and you know, year by year there is well, it's not doubling, but it's really growing pretty rapidly. So, you know, if you are in the HIFU business or in the HIFU area, that's a good place to be, because it is growing and there's a lot of interest. And I believe there's a lot of good things that we can do for people. Well, there's one more thing that I want to mention before I go into, you know, sort of basics, is that there is also, you know, a pretty big field of non-medical HIFU applications. And they're more or less located in some kind of cosmetic business, for example. Very successful, very efficient, like our therapy, or you know, the one for fat reduction. They're also sort of employing the same theories and similar devices. Obviously, the application is different. Anyway, so well, let's come to the basics, and well, I will just bring up the simplest things. I apologize for those who are deep into it. Well, we are, you know, we are talking about longitudinal waves. That means we have the particle movement that is basically in the same direction as propagation of the wave. Our basic property of the wave is its frequency and wavelength. And those two are linked by, you know, by the speed of sound. And actually, I think it's a miracle that actually in the human body we have so many different organs, but all of them share very similar speed of sound. That's the enabler for actually ultrasonic diagnostics, but also actually for the therapeutical ultrasound as well. So we have all that speed of sound of close to, you know, speed of sound in water, which is around 1500 meters per second. It's a little bit higher in human body, but the differences are very small between very different organs. Obviously, the bones are the only exemption in this one. Anyway, moving forward, we also have this in the linear, you know, linear case. We have also this formula that's linking the pressure with the particle velocity through actually through the acoustic impedance. And acoustic impedance is something that we always have to remember, because we are dealing with the wave propagation. And it's like in the radio frequency sort of area. Well, I mean, we always need to understand that there should be a impedance match, or if there is no match, then there is no energy transfer. And that's really something that is important. And I'll come back to that a little bit in a moment. And then one more slide like this regarding the acoustic intensity. So, you know, we are talking about high acoustic intensity, or high intensity ultrasound. And it's good to understand that the intensity is a physical quantity that can be interpreted as power density per unit area, which is kind of interesting, because that's the single parameter that we look at. And I apologize for those who are, you know, really into those formulas. I'm not using the vector notation, but we need to remember that, you know, pressure is a scalar, but velocity is a vector, and the same goes for the intensity, which is a vector. Usually people look at or show this formula that I'm not now pointing, you know, saying that, well, we have pressure and we square the pressure, divide by the acoustic impedance, and we have intensity. Well, what we actually estimate is a magnitude of acoustic intensity. But nevertheless, those things are actually, you know, used in practice, and that's the way to sort of understand the field. Then one more slide. Well, you know, coming to actual wave and how we characterize the wave. So I'll now point at this little chart showing the pressure. Usually pressure comes in some kind of waves, wavelets. In linear case, obviously we have the peak compressional pressure equal to refractional pressure. But in nonlinear, that is actually pretty common in case of high intensity focus ultrasound. Then we have the peak compressional pressure is way higher than the one in the refraction. And we need to remember that in case of this nonlinearity, we might deal with some kind of a formation of the shock wave. I'll skip that part in this webinar, but that's an interesting and important topic. In that case, actually, this peak compressional pressure goes really high, and the third power of the amplitude of that peak compressional pressure is actually responsible for heating in that case. On the other hand, we also need to remember that the refractional pressure is also important, because that's the one that is sort of determining the mechanical effects, especially the cavitation. And then again, well, if we square that pressure, then we arrive at intensity, at least the magnitude of intensity. And again, we can estimate several different parameters based on where and how we estimate our integrals over the peak or the whole duty cycle. And those are actually shown on the left-hand side. One more thing is that pressure, it's a scalar field. So it's a three-dimensional structure, and whenever we do measurements, we always need to remember that it's not only the temporal behavior that we have to somehow capture, but also its spatial distribution. That's why, usually when we look at those parameters of the acoustic field, we have to basically say how we did that in temporal fashion, but also in the space. And usually we like to sort of look at where the focal point is. So that would be the maximum intensity. I'll come back to that. There are some details about how it actually really is. But in many cases, we like to report several different parameters that are actually occurring in the spatial peak, and that would be sort of this part of the chart. And by the way, well, for those who are actually going into the medical device business, there is this standard IEC standard called 60601-2-62 that is basically outlining all those things that have to be reported as a part of the sort of qualification of the instruments that is dealing with high intensity focus ultrasound. Actually, that one is about kind of broader, about high intensity therapeutic ultrasound, but nevertheless, those numbers are actually important.
Ramesh,
yes,
I have a question.
Sure.
Actually, I promised that I would say that people could put questions along the way.
Excellent. Yeah, absolutely. Yeah, thank you for the reminder.
But one question now, can you say something about the duty cycle? So when you have these wavelets or pulses, what's the duty cycle? How many % of the time?
Yeah, well, it's anything between non-zero and 100%. So basically, again, I think I cannot stress it enough that several different devices, they use very different modes of operation. So some of them have a limited duty cycle for many different reasons. For example, for safety, patient safety reasons. Some of them do operate in a sort of continuous wave. It's if the wave is produced in a pulse duration of seconds or minutes, it's really continuous wave. So there's no duty cycle whatsoever. A different story goes when we actually want to measure those things. So then basically, if I come back to this, if we measure the field, then obviously we will greatly reduce the duty cycle, because we are interested mostly in the parameters or properties of the pulse. We are not interested in what happens in between, because the pulse is really the thing that gives us this ISPPA and all those things that have to be reported and they have to be understood. But again, I think that there is the common thing of calling those devices HIFU. However, they do operate very differently depending on the indication, on the mode of operation as well. There are some different modes of operation. So I'm afraid that would be the answer, that it differs.
Okay, very good.
All right, thank you for that question. Well, coming back to to the numbers that people are reporting and what the difference is. So here we have this little sort of overview of frequency range and intensities and pressures that are sort of attributed to different applications, and we have a mixture of the therapeutic and diagnostic applications. And one thing that is really important to say about HIFU, it is really high intensity. It is I mean, we are in the really high intensities comparing to anything else. Obviously, I think I would say, well, the frequency range now, we know it can be easily stretched to 20 megahertz, as we are, for example, operating 20 megahertz. Same story with the pressures. I think pressures are a lot higher, could be a lot higher, depending on what we wanted to do. But anyway, I think the takeout is that high intensity focused ultrasound is called for a reason, high intensity. Right. So, well, let's look at, so we have an understanding that we need to know that there is a field, there is a pressure, there is intensity. So, what do we do about it? So, well, we have to generate it using a device, and the simplest one would be basically a circular radiator. Obviously, there are some formal requirements for that device to be regarded as the circular radiator. I'll just skip them. It has to be thin, for example, specifically thin given the wavelength and the aperture. But nevertheless, even an unfocused aperture, basically a round piece of piezoceramics, for example, from CTS ferroperm piezoceramics, could be a very good radiator. So basically, if we build it this way, so the back of it is air field, so there is only air on this side, which and air is known to have super low acoustic impedance. Then we have some kind of a medium, let's say water in the front of the radiator. Then that energy will be at least 50% will be radiated into the water straight away. However, the other 50% will go into the other side of that transducer. But coming back to our discussion about the acoustic impedance, that actually radiation will be actually reflected back and radiated into our medium. So basically, we should expect really high efficiency of that kind of radiator in general. So that would be one of those things that we would use, or those theories that we would use to build HIFU transducers. Then coming back to our unfocused aperture. So basically, that one has some kind of a focal point, natural focal point, which is determined by the aperture and the wavelength. Obviously, the higher the frequency, the shorter the wavelength, the further away this point is. But the acoustic field has a very specific behavior. So there's this near field behavior, so-called, and then after that characteristic distance, there will be a far field behavior. And in the near field behavior, we have some kind of a parallel beam that is sort of going and following the aperture of the transducer, after this ZR, the dimension, it will basically just divert. And there are obviously some other formulas describing how the field is diverging, and so on. Nevertheless, it's just, it's a starting point to have some kind of focused transducer. Again, I think, then going into focusing radiators, I am not talking about, there's probably another webinar about actually focusing techniques that one can use. I'll just mention a few of them. One of them, the one that I'm going to talk a little bit more about, is basically to use some kind of curved radiator. So the source has the certain curvature that is actually producing focused ultrasound. However, that effect can be achieved using annual arrays, with the control of the phase of different annuli. It could be also achieved using, for example, acoustic lenses that would actually focus the specifically, shaped lenses that would specifically shape the the focused ultrasound. Anyway, coming back to our focused ultrasound, there are some very, very specific things about it that are actually interesting. And one of those is this F number, which is actually giving us some kind of understanding of how sharply the transducer is focused And it's really important because that actually determines the size and shape of the focal region. And you know, there's some ways of actually defining the focal zone. So we like to use this -6 dB or 6 dB, the definition that actually says that we take the pressure in the maximum point. I'll come back to the topic where that maximum intensity or pressure point is, and then we basically look at the space around it, and we just cut it off at the 6 dB drop. That's a very good actual definition of the focal zone. And then, depending on the application, again, some really want to maximize that volume because they want to maximize the efficiency of the treatment. That happens for transducers that are actually really targeting some large tumors inside the human body. However, for example, in a case of targeting very shallow tissue, we would actually really benefit from having the focal points very small. And actually, you know, in here in this little cartoon, you can see those basic parameters of the focusing transducer or radiator. You know, it will have this aperture, you know, A, and diameter actually 2A, and then radius of curvature R, and then there will be this focal point that has actually, we need to sort of imagine that there is some kind of ellipsoidal volume that is the 6 dB. Defined by the 6 dB drop of the pressure, and it will have some kind of depth of focus, and also it will have also this focal diameter. And actually, interestingly enough, those are actually linked to the parameters of the. They are actually predetermined, and they are linked to the parameters of the radiator. Through very simple formulas, actually, you know that that diameter is actually proportional to the F number. So the smaller the F number, the smaller that focal diameter, and also, you know, the depth of focus actually is proportional to the to the square of the F number. And remember that there's also wavelength. So actually, again, the higher the frequency, the smaller the focal point. And that's a takeout from this slide. It's very important because that really determines how we treat our tissue and what happens in our actual application. One more thing about the high intensity focused ultrasound is that, you know, we know how to focus. We need the high intensity, and the high intensity actually comes from two different things. One thing is actually how hard we drive our transducer. Roughly speaking, sorry for my language, but that's how it is. We actually want the transducer to produce high pressure at its surface. So that's number one. But the second factor for the high intensity is actually something that's called focusing gain. And, you know, there is a linear focusing gain. There could be some other factors, but the basic idea is that actually, because we start with a large radiator and we actually take all that energy, or that energy that is actually then transferred to a very small area, then there's this focusing effect. There's this focusing gain effect that is very, very efficient. And actually, in you know, and then we have a very simple formula linking actually pressure at the surface of the radiator to the pressure in the maximum focal point, or in the focal point, let's say. That's actually this ratio, and we see that is actually related to the, you know, how our aperture relates to the radius of curvature, and is also inversely proportional to the wavelength. So again, it's proportional to the frequency, which is actually very interesting. So the higher the frequency, the higher the focusing gain. And this factor can have a value of, you know, from tens to several hundreds if we get our transducer right. So that's a very efficient way of doing it. And then there's one more comment about, you know, where this the maximum pressure point is. So basically, in general, that maximum pressure point doesn't have to be in the actual geometrical radius of curvature point, in this, let's say, the center of curvature. It's not there. It's actually usually closer to the transducer, and actually it is it is sort of moving towards the center of curvature with the increased focusing strength. And I'm actually sort of omitting right now the whole discussion about the focusing strength, but there is a theory actually describing how strong the focusing is. But for the strongly focused transducers, by the way, there is a little reference that it's here, and I would recommend actually there's this topic is discussed there. So basically, we can say that if for the strongly focused transducers, we actually have sort of those two things coinciding. So we have the radius of curvature is sort of the place where the maximum pressure is. However, in general, it's not the case. Okay, I'll just move on. Well, there are some, there are some models, and we can actually show how the frequency impacts the size of the focal zone. And this is, by the way, that the pressure is normalized. So basically, those peaks would be, would be higher for the higher frequency, as because we want to conserve the energy. So, but anyway, there are relatively narrower because of the impact of the wavelength that I showed just before. And same story with how this F number, actually FN stands for F number here, actually sort of determines or predetermines how the acoustic field looks like. So the takeout from those slides is that basically we need to really remember. I mean, we need to understand what we want to treat, how we want to treat it. And then we need to understand, what was the F number of our transducer, what's the required intensity, what's the required power, what's the expected pressure field or pressure level. Speaking of the pressure level, again, there are several different techniques, and I'm going to cover a little bit the techniques of actually showing the pressure and measuring the pressure. So some of those are covered by the measurement using acoustic tank and hydrophone. So basically, the idea is that we have, we immerse our transducer, we stick it into the water, and then we scan the space around our acoustic field using hydrophone. And this is, by the way, that's the hydrophone as well as the acoustic tank produced by Precision Acoustics in the UK, and we have a system like that, and we are very happy. Thank you guys for this one. I'm mentioning basically this fiber optic hydrophone. There is another technology that is used for hydrophones, which basically is employing the PVDF and the needle hydrophones in general. We really like those fiber optic hydrophones. I have another slide on this one because of their broadband behavior. They really are broadband, going above 40 megahertz and so, and it's relatively flat response. And by the way, I mean, in general, when we measure voltage, and the voltage carries some harmonics, and then in order to actually understand actually carries more information about the frequency than just the frequency of the transducer. So in general, actually we obtain the pressure by looking at the inverse Fourier transform of the ratio, basically between our signal that we measure in the frequency domain and actually the frequency domain sensitivity. That's the general requirement by the IEC standard as well. Coming back to this fiber optic hydrophone, I will not maybe go into details. However, it's an optical measurement in essence, looking at how the acoustic wave interacts with some kind of a membrane in the tip of the fiber optic, which is 100 micrometers thick. However, the actual let's say active area of that hydrophone is a lot smaller because it's determined by this fiber core, which is around 10 microns, and that's really that's a beautiful feature of this hydrophone, because it gives us this good spatial resolution that we really need, especially when working at high frequencies as we do, for example, at 20 megahertz. And there's been actually a number of papers dealing with the spatial averaging due to large hydrophone diameter. And recently, Keith Weir from from FDA was actually pointing at challenges due to spatial averaging and then impacting, for example, some thermal indices that have to be reported when actually characterizing ultrasonic systems. Anyway, so that's one thing that we can use to characterize the field. And some examples again from our paper, let's look at the axial pressure distribution. So we take a transducer and we have this main axis that goes from the center of the transducer. That would be the axial pressure. And then, we have a case for 3 megahertz and 20 megahertz. So, and the pressure comes, actually the beam direction is so that the transducer is on this side. So that would be the focal point. And then we could actually measure, the dashed line is the measured field. And then we have some certain characteristics like this depth of focus at 3 dB cutoff, 6 dB and 12 dB cutoff, and same story with the diameter. So basically here we can already see that, if you operate at 3 megahertz, our zone, 6 dB zone is actually 2.5 millimeters. So it's a large zone comparing to 490 microns. Same story goes for the diameter of that focal zone, which is 380 for 3 megahertz, and actually only 80 micrometers at 20 megahertz. So actually operating at 20 megahertz is actually sort of microwave device for actually ultrasound for mechanical waves. Well, one more result, obviously, if we have a scanning device and can go 3-dimensional, then we can actually make some kind of a planar scans. And in this case, we actually did the planar scan, and we also reconstructed the 6 dB volume or 6 dB focal zone based on the 2D scans. And the arrow is actually pointing at the direction of the ultrasonic field. And then if I click it, hopefully it runs. Then we actually see how that field is being produced, and how it actually looks in the 3-dimensional space. Well, moving forward. So basically, another super important instrument is the radiation force and force balance, and actually measuring the radiation force. The idea is pretty simple. The radiating device is actually producing radiation force that can be then absorbed into the target. And target, in this configuration, the target is fully absorbing. And then that one will basically sort of impact the force that is put on the microbalance arm, and then transferred into the sensor of the microbalance. So we will see some kind of a non-zero force due to the acoustic power, and that one is actually linked linearly with the properties of water, basically, and speed of sound and some other parameters. Anyway, there's a proportionality kind of relationship between the acoustic power and the reading from the microbalance. And the basic thing that we would like to know is this electroacoustic efficiency of the transducer. So how much power goes in and how much power goes out, roughly speaking. And so we take the acoustic power and the electric power, and we divide those two, and we come up with some kind of efficiency. Usually that parameter, this electroacoustic efficiency, is not constant. It depends on several different things. In the low power region, it's not always constant as well, but it's more like saturated. However, it has a tendency to drop with the higher power levels due to some losses, and it's not only losses in the acoustic part, but also in the electronic part of the device. So that's it. Another technique that we sort of employ, at least at TuSonics, is Schlieren imaging. It's a very useful technique. It allows us to actually capture the sort of inhomogeneity in the medium, which is water in our case, due to the acoustic field. So it's not a really direct measurement of the acoustic field. We know that it's actually can be calibrated. We know that there is some Schlieren, qualitative Schlieren systems. However, our system is only quantitative. We make pictures or images, Schlieren images of acoustic field. However, it is really useful. our system uses a really very classical Toppler's topology. So we start with the light source, and then there is this horizontal slit that is sort of predetermining the light. It is a diverging light, and then there is a collimating lens that is producing collimated light that goes through the test area or test volume inside the water tank. Then there is a device under test. Behind it, you cannot see it here, but there is actually focusing lens that is focusing the beam onto the edge. We are using actually horizontal edge configuration. And then there is some kind of imaging lenses, and then it goes onto camera sensor. So that's basically how it is. We have a capability to rotate very precisely the transducer. So basically, we end up having some kind of a tomography picture of, you know, the acoustic field, looking at it from the side. And what you see on the right hand side is a kind of example. So it's the tomographic slices, Schlieren slices of focused ultrasound field, and basically at different angles of projection. Well, yes.
Sure. We have a question, maybe just to give you a chance to breathe.
Sure.
I'll just take this question now about radiation force measurements. So,
right.
so Gillens is asking, why do you prefer radiation force measurements instead of a 2D scan of hydrophone measurements?
Well, I mean, the answer is very simple. So there are some limitations to how far you can go with your measurement when it comes to the hydrophones. They actually cannot take really high pressure fields. So you are actually limited to some kind of quasi-linear operation of your transducer. That's not enough to actually understand the full extent of the behavior, and especially the electroacoustic efficiency. That's why, you know, the real high power measurements are made using the radiation force balance. That one is really allowing us for, you know, we can pump as much power as we want. Obviously, we need to remember that, you know, we need to take it in the post-focal fashion, and there are some different things about, you know, how we deal with the target. However, you know, radiation force balance is actually basically the only good measurement, reproducible, repeatable measurement that actually characterizes the overall average behavior of a transducer. So that would be the reason. I think I need to just sort of speed up a little bit. Coming back to our Schlieren, so Schlieren actually can produce also videos, and well, there is actually a video of a focused ultrasound. So this is just the tip of the tip of the field. Being chopped, as you can see, is modulated, and we can clearly see the focal point with the central lobe and some side lobes. We also actually have the particles there, and they are showing us this effect of streaming caused by the focused ultrasound. So I'll just move on. So I'll now talk a little bit about the topic that is very close to my heart, is the HIFU in dermatology. So basically, well, as in any other application, the dermatology can actually really benefit from using focused ultrasound, because we can actually produce ultrasound that is operating within the thickness of the skin. And human skin is the biggest organ of the human body. We need to remember that. So that's very important. However, it is very challenging because it's very shallow. So if we really want to be precise, and that's really what makes the difference in terms of using HIFU, we need to be able to operate within the thickness of the skin. And we have a little cartoon of a skin. And so typically human skin is around 1 to 2 millimeters, in average 1.5. So if we want to be very precise and target actually things that are within the dermis, and actually there are specific indications, specific diseases that are only in the upper dermis, or maybe even in the close to the membrane. So then or epidermis, then really we need to be very precise. That means our focal points have to be small, and this is really why TuSonics is operating at 20 megahertz. And actually, this is one maybe comment about actually in general using HIFU. I mean, I know there's many people actually using HIFU, for example, for some kind of brain stimulation, and they use a lot. They make a lot of experiments with the small animals. Mice, for example, the brain is around 5 millimeters. I mean, I'm sorry, I don't know exactly, but it's in range of millimeters, and actually claiming that you can target very specific areas of a 5 millimeter object with 2 megahertz, or actually 1 megahertz, half megahertz ultrasound. I think it's really difficult to understand from the physical point of view. You actually really need to operate at really higher frequencies to have confined focal points to actually make some kind of claims about where we operate. And same story goes for human skin. Again, human skin is about up to 2 millimeters in thickness. If we really want to make very specific treatment within the dermis, we need to operate at 20 megahertz. There's not even 10 megahertz not allowing us for this precision that we really need. And one could actually say, well, maybe you don't care, maybe you just take off the whole skin. Well, the whole difference is that the shallower the treatment is, the quicker the healing process goes, and the less probability for scarring. So that's really, this is the game. This is really what makes the difference. And then moving on, there is an actual device that is actually allowing for a skin treatment. It's there's no surprise to Sonix is a producer of that device. The difference is that it's not only high frequency, but it's also having the built-in optical imaging capability, which is very, very unique. So actually, one can look at the skin or human skin while doing the treatment. Then there's a few different modes of operation that are actually possible. One is so-called ablative, when we actually create some kind of wound crust that will then come off after 5 to 10 days, together with this pathology that we want to remove. And another one is non-ablative, meaning that we are actually doing the treatment deeper in the skin and then causing some kind of a local deep necrosis that then will be accommodated by the vascular and the lymphatic system. There is a lot of things that one does with HIFU. In our case, we are doing a lot of preclinical, for example, tests on so-called tissue mimicking phantom. In our case, it was a sort of polymer gel with some kind of protein in it that would actually be transparent, and then it would turn white upon exposure on focused ultrasound, and then you can see how well the depth can be controlled. And actually, there is no change in the structure of the tissue above the lesions and below, but only in the specifically predetermined focal point. And by the way, what we're looking at, they're actually cross section through the tissue mimicking phantom, and the direction of the HIFU or the beam is from the top, sort of. So it can be actually really well defined, well controlled, and can be actually well visualized as well. Well, one could actually wonder about why this triangular shape. We did some deeper modeling of it, and what you can see, you see some kind of frames at several time points or timestamps up to 500 milliseconds of sonification, and then we can see that this thermal field is sort of shaping into the triangular shape that we see actually in the phantom. Obviously, there's a lot more details to it. However, that's the general understanding of it. And obviously, we definitely need to show that actually it works in the real settings. There are several actually different diseases and indications that can be treated using this focused ultrasound with the optical imaging. All of them sort of are somehow related to the diseases in epidermis and dermis. That's why they're all possible. Some of them have been already demonstrated. Some of them are waiting to be demonstrated. And that's how it looks. You see, that's how it looks in the regular clinical setting. Again, coming back to one of my first slides, you could actually compare that with some other devices that would actually require, MRI and some very sophisticated kind of place. However, this one is actually operating in a very simple, treatment room of a simple clinic that can just be used for this purpose. Another thing is that we can actually use this optical observation to follow the treatment, even though it happens deep or below at least the surface of the skin. We can actually see it, and what you can see on the left hand side, this is actually actual treatment. It's actinic keratosis before the treatment. Then we can see individual pulses of the HIFU actually being applied. So we see some kind of a characteristic actually change in the color. And then this is kind of halfway through the treatment, and this is after the treatment. So actually, one can see real time what happens in the treatment or treated area. And we have a little video showing actually treatment of an angioma. So it's a kind of a vascular malfunction. So it's a kind of a cherry mark that a lot of people have. It's a benign condition, rarely treated actually, but it's pretty good to visualize how it happens in the real time. And so basically what you see right now, I'll start the video. What you see, we're observing the surface of the skin. We see it. We see our little vascular malfunction, and then we start pulsing the HIFU, and then we see that there are some changes within or below the surface of the skin, basically coagulating this lesion, and then that's over. That's it. This little angioma that was around 3 millimeters in diameter, that takes 3-5 shots, and it's gone. We have some clinical stars. So basically, I think we're coming to the end of the presentation. I think it's pretty good. We still have time to discuss the materials. Some few examples. So this is this angioma. That's a different case. However, angioma has a similar size. So that's before treatment. That's 12 weeks after the treatment. We can see still some kind of a redness. And then, by the way, this is how it looks after 16 months. So a little bit of hypopigmentation. However, it's the cosmetic result is really, really good. Then another case, it is another kind of angioma. That's a congenital angioma. It's a 40-year-old lady living with that entire life. Everyone was telling her, well, it's impossible because any treatment would actually make it worse, which was true, until she actually met our clinician, and he actually proposed the HIFU treatment, closing actually those deep supply of the blood into the skin. And then you can see, well, actually, that's the 12 weeks after the first treatment. She actually underwent another one, just really clearing it off, making very different sort of quality of life kind of experience for her afterwards. Another case is the seborrheic keratosis, very, very, very popular, also benign. However, it's really very, very frequent on faces or some other human body parts, like this one. Very good, again, results after I believe there was two treatments in this case. What you can see on the right hand side are actually dermoscopic pictures taken in polarized light, showing all those dermoscopic features of SK before and actually no SK after. Another case, viral warts. That's kind of unusual location on the nose, a little here in the base of the nose. Again, it seems like a very, very typical condition. A lot of people suffer from that. And there are treatments. However, as we learn slowly, a lot of treatments are actually inefficient, including even surgery and other things. So here actually HIFU also comes to the rescue, and this is 8 weeks after the treatment. I think it's been already 2 years for this patient, and we see no occurrence. Well, and myself, I also actually underwent a little SK removal on my right cheek. Before, you see some kind of a brownish kind of a spot. Actually, I have more of those at the moment, but this one is gone. This is only 13 days after the treatment. So it's actually, you can see that, you know, it was very superficial. The beauty of this of this high frequency HIFU is that it's extremely superficial. If we want it to be superficial, that means the healing goes very, very fast, and the scarring is very reduced, or actually impossible almost in this case. Another condition is a hyperplasia of a sebaceous gland. Actually, there's no actual treatment for that, and this is the one, and this is 6 weeks after. So that's really a new area of applications. And then two last applications. One is actually tattoo removal, and in this case we have a rat tattoo that is known for causing a lot of actually allergic reactions in those who have it. And it was originally it was removed by shaving. So this is after shaving. But obviously rat tattoo mixed with blood during the shaving is not really giving a good precise removal. So there's always some kind of residues left, and those would still cause some kind of allergic reaction. On the top of that, actually, the typical treatment would be to use lasers. However, lasers would actually fragment the pigment, the red pigment, that would then go into the vascular system and the lymphatic system of the patient, cause further deeper actually allergic reaction. So in our case, you know, this patient came to the clinic, and then actually he was treated with the HIFU. So it's only to clean up those residues of the red, and actually it was very successful. No red pigment, and it was actually expelled rather than sort of accommodated by the body. And the last one, really, this is the direction where Tusonics goes, is really into those very important serious indications, and basal cell carcinoma is one of those. It's a most prevalent cancer in the world. Actually, people don't realize that there's so many cases of that cancer, and that's actually skin cancer. So this case was one of the first cases that were treated. It was nodular BCC. That lady she refused any other forms of treatment, and then she was offered this HIFU treatment. And then after 12 months, there's no recurrence. There was also the follow-up with including the actually biopsies that confirmed that there was no BCC after the second treatment. And this case is also interesting because shows that we can actually preserve the hair follicles. In many cases, you know, the concern, if it's the BCC on the head, it's within the hair area as well, and some treatments would actually remove also the hair, which is the concern for patients. In our case, because of this very precise location of the focal point underneath the skin surface, we actually can preserve easily the follicles, because they are deeper than actually the BCC that we treat. And then coming back to the basics. So the main technology that is used in HIFU is actually piezoceramics or piezoelectricity in general. And in here, actually, I have those materials that are of interest for HIFU. All come from CTS ferroperm piezoceramics. Thank you by the way, for supporting the data gathering. Many thanks, Erling, for that. So what can I say? I mean, from the perspective of the HIFU device, the designer, there are some few things that we really want to look at. And first of all, we would like to look at the permittivity. And by the way, there is also another column that is sort of outlining alternative soft PZT that is not used for HIFU or any high power applications. And there are reasons for that. However, you know, I mean, recently we want to challenge that, but well, that's off the point. I'll just come back to this dielectric permittivity. So that's basically number one that we look at. And we can see that well, there are different materials and different permittivities available. It determines basically there's this kind of the capacitance, the electric capacitance of the device that we have to drive, and that one actually also impacts the impedance that we have to match. So in case of large transducers, especially operating a high frequency, we would really benefit from having low permittivity. So basically and those that are actually in low numbers, in low hundreds, they would be really good. On the other hand, there are some special materials developed for HIFU by Ferropem, you know, for example, PZ 52 or 54 that have really high permittivity, and they would be really good for small transducers, you know, for example, when they go to multi-element or you know, hundreds of elements arrays, HIFU arrays, they would be probably good for that. Then another story is that, you know, dielectric loss again. Well, we have to, in the end, we have to drive some kind of lossy capacitor, and then that loss will be turned into heat. So we want to look at materials that have low loss. And again, you know, at least 4 of those 5 materials, they actually exhibit pretty low losses. Then there's a number of things that we obviously need to look at, you know, operational temperature and recommended temperature. However, to be honest, you know, HIFU devices, they usually are, you know, they operate at resonance frequencies. And really the thing that makes them or breaks them is the quality factor. That is actually, you know, the reciprocal quality factor is the mechanical loss. So we want the material that really rings as long as it can. And that is really reflected in the quality factor. And that's why actually those materials with the quality factor above 1000, that's really something that is really cool. And we have at least 3 of those in here. 500 is not bad. And actually I would point at this PZ34, which is kind of an outlier because it's not PZT, is only PT, as we discovered recently. And it has different couplings. I didn't speak about couplings because they, you know, in the let's say regular one more in the sort of regular setting, we don't really see any big benefit of comparing the couplings. However, in case of PZ34, we see this huge difference between the planar and the thickness couplings. And that could be actually an interesting material for example, to tackle this the well-known problem of Lamb waves being propagated across the large transducers, and there is several papers actually dealing with that. So that's actually an interesting thing. So I think with that, I know it's already 3 minutes after, and I was supposed to actually end before that. I apologize for this. I would say thank you for joining in, for tuning in. There are contact details in case you are interested in anything or in a discussion, or I said something wrong.